name is Ramy Sedhom, and welcome to the GRACE Cancer webinar series on bladder cancer. We are lucky to be here with Dr. Matthew Galsky from the Tisch Cancer Institute at Mount Sinai. We'll be talking a little bit today about metastatic bladder cancer, but before doing so, Dr. Galsky, can you please introduce yourself, what your interests are, and a little bit more about what you do?
Absolutely. So my name's Matt Galsky. I'm a medical oncologist, and I work here at Mount Sinai in New York at the Tisch Cancer Institute. I'm the director of the Genitourinary Medical Oncology Program and co-director of our Bladder Cancer Center of Excellence. And my interests are caring for patients with bladder cancer and clinical development of new therapies to treat bladder cancer.
Fantastic, and thank you for all that you do. As you know, we'll today be focusing on the role of immunotherapy in metastatic bladder cancer or stage 4 cancer. But before doing so, Dr. Galsky, how do you typically explain immunotherapy to your patients in clinic?
So immunotherapy is a broad term, of course, and the immunotherapy that we're typically talking about these days are a class of drugs called immune checkpoint inhibitors. Sometimes these treatments are described as activating the immune system. That's not technically how they work, and so I try and provide some information about how we think that these medicines work without going too much into the weeds, and typically describe it in this way, that cancer cells have co-opted a mechanism that the body typically uses to control the duration or the intensity of an immune response. If you get an infection, your body has to have some way of turning off the immune response when that infection clears. Otherwise, it would keep becoming active and you'd keep having inflammation, etc. So your body's developed these mechanisms. Tumors are smart. They co-opt these mechanisms and they hide from the immune system. And what these drugs do, what we think they do, is peel back that layer that the cancer cells use to hide from the immune system.
Great, thank you for explaining that. Now, kind of honing in on bladder cancer itself, when thinking about the first-line treatment in metastatic bladder cancer, how do you decide between chemotherapy and immunotherapy?
So that's evolving. Traditionally, we used chemotherapy with drugs that included a platinum chemotherapy drug, either carboplatin or cisplatin, for the past several decades, and that was really the standard first-line treatment for advanced or metastatic bladder cancer. A few years ago, the immune checkpoint inhibitors, these immune therapies, were developed and approved for use in a select subgroup of patients with metastatic bladder cancer who weren't eligible to receive the drug called cisplatin because of other medical problems like poor kidney function that sometimes patients with bladder cancer experience. And so that became a standard first-line treatment for patients in that setting. Subsequently, the data informed us about how to use these treatments in an even more refined way. And the data showed us that if tumor cells express or cells in the neighborhood of the tumor express a protein called PD-L1, which is a quote-unquote target for these immunotherapy medicines, then maybe those patients are the best candidates for immunotherapy. And so currently, we think about the first-line treatment of metastatic bladder cancer like this. If patients can get the drug cisplatin, the chemotherapy drug cisplatin, that remains a part of standard treatment. If the risks of cisplatin would outweigh the potential benefits, then we think about using immunotherapy alone. If there's a high expression of this protein which predicts benefit, and if there's a low expression of that protein, then we think about using alternate chemotherapy.
Fantastic. And we do know that the data, as mentioned, is evolving even across different tumor types, and big push for some drugs to kind of get into the first line. So as the field is evolving, and let's say a patient is eligible for either chemotherapy or immunotherapy, are there some theoretical benefits of getting immunotherapy first?
There are some theoretical benefits of getting immunotherapy first. There are some theoretical benefits of getting chemotherapy first. And a lot of this has to do with what an individual patient is most likely to benefit from. And we have some clues in that regard, but we're not perfect at making those assessments. And because we're not perfect at making those assessments, I feel that that's what's really driven the success of combination treatment in some other types of cancers like lung cancer, where giving chemotherapy and immunotherapy together is really a standard treatment. In bladder cancer, we have the preliminary data for that approach, showing that if you give chemotherapy and immunotherapy together as the first-line treatment, you can delay the time when the cancer starts to progress or grow. And whether or not that treatment ultimately leads to a benefit in terms of how long patients live, we're still waiting for that final data, which is really what we use to help us inform clinical practice. And so there is a rationale, a conceptual rationale for giving chemotherapy first or for giving immunotherapy first. But because we're not as smart as we hope to be in terms of making that determination, that might be one of the reasons why receiving both treatments together is a viable path forward.
That makes a lot of sense. Now, kind of transitioning a little bit, we do know that there are different immunotherapy agents approved in the first line, and some that are not available in the first line but available in the second line. So, can you kind of walk us through how you think about the 5 different checkpoint inhibitors that are approved for use in bladder cancer?
So there are 5 immune checkpoint inhibitors approved. They're either PD-1 or PD-L1 inhibitors. These drugs block 2 aspects of a handshake, one could think. So one blocks one hand, the other blocks the other hand, and really working via the same mechanism. There are some nuances in terms of the drugs with regard to the frequency of administration, with regard to some of the aspects of the actual drugs themselves. But in clinical practice, there are probably more similarities than differences. Where some of the nuances do occur, though, have to do with the clinical trials that have been done, the design of those trials, and the level of evidence that we have to support using some of these drugs in different contexts. And what I mean by level of evidence is our highest level of evidence that we have to inform medical practice is when we do large randomized clinical trials with a new drug versus an old drug and show that the new drug works better, makes patients live longer, ideally is safer, and makes patients live longer. And we have that data for some of these drugs in certain contexts. And so we have that data for the drug pembrolizumab in patients who've already had chemotherapy and then have progression of their cancer, quote unquote, second line treatment. And so pembrolizumab is a very standard treatment in that context because of the availability of that level of evidence. That's not to say that the other drugs wouldn't meet that bar. It's just that oftentimes the trials haven't been done to demonstrate that. In the first line setting, we have 2 drugs that are FDA approved for patients who can't receive the chemotherapy drug cisplatin, and both of those drugs were approved based on what we call single-arm clinical trials, where everyone got the same medicine. There was no randomization to a different medicine, and that was the basis for those approvals. Now with the drug atezolizumab, we actually have randomized data based on a trial that I was describing before that involved the combination with chemotherapy as well. And so we have preliminary data which really has informed our use of atezolizumab in patients in the first line setting who have a high level of expression of this PD-L1 protein. So really atezolizumab and pembrolizumab as first line treatment are the standards based on the FDA availability of these drugs in that setting.
Fantastic. And we know that you've been a leader in terms of some of these clinical trials, so we appreciate all the work that you're doing. Another question that comes up a lot of times in clinic, we have patients ask about targeted therapies. One specific question that we wanted to ask you, what is the role of FGFR inhibitors in bladder cancer?
So FGFR, fibroblast growth factor receptor 3, specifically FGFR3, is a gene, and it's a gene that's mutated, meaning that there's an abnormal copy of that gene, not infrequently found in bladder cancers, found in probably about 15 to 20% of bladder cancers. When that gene is mutated, it's like flipping on a light switch inside those cells that causes the cell to grow and divide. And so logically, if you have a light switch like that, if you could switch off the light switch with a drug, that might be the best strategy for that particular cancer. And we know this from other types of cancers where there's been a similar phenomenon with other genes, like in lung cancer, where this occurs in actually several different types of genes. So based on that knowledge, there were drugs developed to try and block this mutant protein. The first of those drugs is now FDA approved, commercially available, called erdafitinib. Erdafitinib is approved in patients who've received chemotherapy, who the chemotherapy has stopped working, and who have a mutation in this gene within their tumor. And that's a medicine that's given orally. It's a medicine that is now part of our standard treatment armamentarium. And so while in the past, molecular or genomic testing of bladder cancers was often integrated into practice, but without a clear understanding of how to use that information, now we know how we can use that information. And so this really should be part of the assessment of an individual patient's tumor.
Great. And finally, speaking of growth, innovation, and new understanding of treatment and disease, are there any exciting developments or research interests of yours that you hope to see in the field in the next few years?
So bladder cancer, the development of drugs to treat advanced or metastatic bladder cancer has been challenging, and we went for decades without a single drug approved, and that's really changed dramatically in recent years because of a number of reasons that really occurred simultaneously, including advocacy in terming the availability of more funding to study bladder cancer, including the development of these immune checkpoint inhibitors in bladder cancer, which really renewed interest from many parties, including the pharmaceutical industry in bladder cancer. And so that's created a lot of new opportunities. And the field has really never been as active in terms of new drug development as it is right now. There are a number of drugs that are probably going to be available in the shorter term as part of our standard treatment armamentarium based on the results that have been shown in studies so far. And those include drugs that are called antibody drug conjugates. Quite simply, these are drugs that are meant to deliver chemotherapy very precisely to cancer cells, rather than giving chemotherapy which indiscriminately flows through the bloodstream and ultimately reaches cancer cells wherever they might be. This is a way of basically addressing an envelope to a cancer cell and sending the chemotherapy drug to the cancer cells. Those drugs have shown promise. We think that those will be part of our treatment in the not too distant future. And then there's a whole series of approaches that are based on better understanding the biology and the immunobiology of cancer that are probably a little bit further off, but I think have the potential to dramatically change how we treat patients in the future.
Great, that's very exciting, and we look forward to those developments. We do want to close off by thanking you for your time to contribute to this webinar series, and more importantly, for all that you do for patients with bladder cancer.
Thank you very much.